do get it. You like to do drywall? Probably don't like to, but like to get it done.
It's not a different one. Yeah, well, it's time to get the job over. You know what I'm saying? It's like where we're putting it into like a it's not drywall. It's really hardy board, but putting it on the inside of a barn. And we've been trying to get it up and running. We couldn't get in there for several months because the weather was so bad.
Drive and
So
Job, isn't it?
yeah. Oh, but you know what it is. What it is. You know, just with the weather, you never know what you're gonna get.
No, sir.
Especially this year, it's been real crazy.
It has, Dr. Dale. I mean, crazy, crazy. Well, what are we going to talk about today on your show?
Knees.
Knees. Oh boy, got to learn about these knees.
We're going to break down the anatomy of the knee, and if it's okay when we start, if somebody wants to, I'm going to put something about Facebook on there. So we're going to be when we talk, we're going to be live so people can see us on TikTok live, or they can get on our Facebook and see it posted. And I think, and Tom, where else is it going to be at? So that way we can, so if people want to visually see, just Facebook and just TikTok live. We'll be live on TikTok, but if they want to go back and look at stuff.
All right, well, here we go.
So you just let me know when you're ready to go, and that way they can visually see some of the models and things like that. Trying to up. We're trying to make things a little better, right?
You got that right. Here we go, buddy. Classic Country 98.1. Good morning, good morning, good morning. Here it is, about 14 after 11 o'clock. I had to step back in the studios real quick here on a Wednesday and talk to Dr. Adam Delp. Dr. Delp, good morning. How you doing?
I'm doing great, Cousin Andy. How about yourself?
Oh, doing fantastic. Beautiful springtime morning. Just beautiful out there. Warmer temps, and got to be loving it all.
Hey, I'm enjoying it. The weather's been really, really nice, and the last few days it's been good, and I think it's supposed to get warmer by the end of the weekend, isn't it?
Warmer by the end of the week, and of course we do need some rain, and we're supposed to get some rain maybe Sunday, maybe a little before that. May have a pop-up storm or shower in there, but we won't complain because we can use a little rain, that's for sure.
A little rain won't hurt us, will it?
No, sirree.
That's right.
Not at all. Dr. Delp, you got new things going on. Been on the social media a little bit. Surprised me last week, and my daughter was telling me, "Says you're on live with Dr. Delp on social media now."
Yes,
I think Facebook, and you got a couple other ways you're out there too.
Yes, sir. And if you recall, we had I think I spoke to you a few months ago, and we had a lot of people calling us saying, "Hey, would you record your show so we can go back and watch it?" And so we didn't really have a way of doing it. So I hooked up with Tom. Tom's helping me out. And we are actually live right now. We're on TikTok. What is the actual address on TikTok? Oh, so it's Delp Chiropractic right now. Delp Chiropractic at TikTok live. And then we're also going to be putting it on our Facebook after the broadcast. So if you miss something or want to hear something, or you just want to hear Cousin Andy talk a little bit more because you love the sound of his voice, then you can catch us out on Facebook a little later on, and we'll be taking some live questions on TikTok. So that way we make it a little more interactive. Also, you can see kind of what we're doing on radio. You can't always see it, but when we put this amazing radio station WBRF tied in with TikTok and Facebook, we're hopefully it'll just help more people to be able to see and also understand what we're going through or what we're talking about, so that way we can help them more.
All right, very good. That's good to know, and I'm sure all your patients and people having problems really appreciate all that, Dr. Delp.
Well, it makes it easier. You know, we have a lot of people that say, would you put this on a podcast or whatever? So after we've had so many people ask us, we finally are doing it. So we're running live. We're working out some little wrinkles because we're just starting it. So if there's some little bumps, hopefully in the next few weeks there won't be any more bumps. We've also always had a good program, you know, with you obviously, and Scotty Too Hotty, or Jay Scott, excuse me. I call him Jay Scott. He might not like me calling him Scotty Too Hotty. If you remember the wrestler Scotty Too Hotty from back in the 90s?
Scotty Too Hotty.
Yeah. So I didn't want. I made sure Scott knew that what I was talking about, so he didn't think that he didn't need to worry about me, you know, trying to pick him up or anything like that. I don't think my wife would appreciate that real well either.
No,
but
definitely not.
So at any rate, so you ready to get fired up, or?
Yep, let's fire it up this morning. What are we going to be talking? You said something about the knees.
You got
today, right?
Absolutely.
All right.
So, knee problems. We're going to talk about the knee itself. We're going to talk about the different problems that you can get in your knee. We're also going to talk a little bit about the anatomy of the knee so people can understand it better, because I have a lot of people that come in and they either touch different spots and it may not be their knee, or they're having a problem and then we can do something to their knee and it makes a huge difference, or they have questions because they had a procedure done and they don't understand where they actually did the procedure, or they've tore something, they don't understand where it's at. So we're going to break that down today, make it understandable. My goal today, or I guess you'd say my mission statement, is how to make healthcare easier to understand and break it down in a way so that way you at home, whether you're listening to me on the radio or you're on TikTok or Facebook listening and watching, that you can understand more about what's going on with your own body. Even if you're not a candidate for what I do, our goal is to get you to the right source and help you to understand what you need or what your real problem is. So without further ado, you ready to get this thing fired up?
Let's fire it up. Let's hear all about the knees.
Let's do it. So first and foremost, I'm going to start off with a little knee anatomy. So if you're looking up TikTok Live or later on Facebook, so this is actually we're going to hold up a knee model. So a knee model, you have, for those on radio that can't see this, you have the knee. You have the upper part of the leg comes into the lower part of the leg, and you have this like cushion in between. We call it cartilage. Okay, so the cartilage acts as your shock absorber. Think about like a shock absorber on your car, which helps to absorb the shock when you drive down the road. So most people, they'll have heard like a medial meniscus. So if you look at the knee, the meniscus is on the inside. That's the medial meniscus. And on the outside, that's what you consider the lateral meniscus. This lower bone, you have like a small accessory bone on the outside. And what happens is when you move your knee, the patella actually moves up or what we call the kneecap. So, breaking that down, the most common injuries to the knee are, when you're younger, you tend to get what's called a meniscus tear. So the inside of that little cartilage or that shock absorber, it gets kind of torqued or twisted, and it can tear it. It can kind of get trapped in between. And so in the past, some people have gone in, and we'll kind of cover some of the different things they do for it, like surgeries and whatnot. And also the second probably thing in the knee is the ACL tear. So you get tears of ACL. So there's a it's called the anterior cruciate ligament. It's kind of in between the knee. And if you have an injury, like say playing soccer or football, and you land and your knee shifts, it can tear that. You also can tear what's called the medial collateral, which is on the inside of the knee, the inside ligament that helps to stabilize the knee. That's probably the one, when we talk about tearing injuries, those are probably the most common ones. MCL, the medial meniscus being the number one, followed up by the ACL and then the medial collateral ligament. Your lateral collateral is actually on the outside. You do see those, but not nearly as often as you see a meniscus. In fact, we call it the unholy trinity, which is all three will tear at the same time, which is your medial meniscus, your medial collateral ligament, and then your ACL, which is inside. So the other option are other people that come in, they'll have arthritis in your knee. So Cousin Andy, when you say arthritis, what does actually the term arthritis mean?
Inflammation.
You got it. So arthro meaning joint, itis meaning inflammation. So say I've said you have tonsillitis, that means inflammation of the tonsils. If I have, let me think, what's another one? Bursitis, you have burses, or these little sacs that go around in your shoulder. When the joint doesn't move correctly, it can inflame it and cause the bursa to inflame. Well, when you have arthritis, that means joint. So that being over the joint. So can you have arthritis that goes down your leg? That'd probably be a stretch. I would say that arthritis usually affects a specific joint. So in the knee, what will happen is you'll actually start to get wear and tear when that moves, and it'll actually wear down that cartilage in the knee. We see a lot of people that will develop a shift in their knee, and then it'll cause it to start to chew up the inside of their knee. Inside of the knee being, if I had 10 patients that come in to see me with knee problems, I would say probably 8 or 9 would have it on the inside of the knee. Very, very few of it on the outside. And a lot of that's because of how the motion is, but also they can develop another problem that can lead to weakness that allows the knee to translate and actually cause pressure and wear down. So think of it, the good analogy I use is if you've got a car and it's out of alignment, what happens to the inside? It would depend on how it's aligned, obviously, but say it's the tire's sitting at kind of an angle, which side wears out faster? The inside. You got it. So if your car is your knee and that knee is actually biomechanically shifted, it puts more pressure on the inside and then it wears it down. And you'll see so many people. In fact, I think I asked a professor this back 25 years ago when I was in school. I would say, well, just curious, why does it wear the inside down? He says, basically he came up with a statement, basically said, I don't know, just that's the way it is. But then the more we've researched it, we found there's some other factors that can cause instability in the leg, which can lead to that wearing down. Okay. So typically you'll get more biomechanical issues in the knee, which will cause the inside of the knee to wear down. And it can also do the same thing outside. I had a guy that the outside of his knee was wearing down, but his knee had actually shifted to the outside, almost like a bow leg. And so it put more pressure and caused that outside to wear down. So there's also a third common issue is what we call patellofemoral syndrome, which is where the muscles in your quadricep or in your thigh don't fire correctly. They're weak on the inside, and so it allows that knee, that when you're moving it, to actually pull the patella in a bad angle. The patella actually moves in a groove, and if those are at home, you can see it. You can actually see it move in the groove. And then when it pulls to one side, it actually causes it to get irritated or inflamed, and it can cause that patellofemoral syndrome. So that's another one that can happen. It's usually more in athletes or somebody who's real active. And then the last one, we see it as often as some of the other issues, is it actually refers pain. So say someone has had back trouble off and on for years, and they just kind of assume that's just life. And then what happens is the nerves that come out of your back, they actually extend, and some of them go down in and actually radiate into the leg. And depending on which nerve is inflamed, it actually can refer pain. What we also see, Cousin Andy, is a lot of times somebody won't have just one. They'll have more than one issue that's actually causing that problem. So let's kind of hit the ground running, as I say. So what are some causes of knee pain? We talked about tears, wear and tear, things of that nature are radiating symptoms. So what are the treatments for that? So when we talk about a knee problem, what's the most common thing you hear when they treat the knee, what they typically do? What, in your opinion, what do you hear the most of?
Probably arthritis would be one of the big ones.
You got it, especially as you get younger in age, we'll say, right?
Well, like
osteoarthritis or degenerative joint disease. Yeah. Same thing. Yeah. So if you have osteoarthritis in your joint, we call it degenerative joint disease. If you have it in your back, and I'll pick up my spine so those at home can see if you're looking, you actually chew the disc down and it actually causes degenerative disc disease. But it's the same problem, just hits the same. It's wear and tear. So if you think about it, it's like that car driving out of alignment. The more out of alignment it is, if it doesn't move biomechanically correctly, it wears down one side. So with the knee, you're exactly right, arthritis. So typically, if you went to, say, an orthopedic or something like that, and God bless them, they do a great job. I got buddies of mine that are orthopedics. Think the world of them. What is the most common treatment they typically start out with when you do when you have a knee pain from arthritis, or really just for any type of knee pain? What's the common treatment?
Injections.
You got it. They use an injection. Mm-hmm. And if I'm an orthopedic, that's my first line I go to. That I respect that. I talked to a nurse practitioner the week before last. She's awesome, great. She says, that's what we do. We do injections, and I respect that. No issues. What more people are trying to, so when they do an injection, they stick a needle in the joint space, and then what they do is they inject cortisone, which is a steroid. So what cortisone does, or steroid, it helps to block your body's natural response. So when something grinds or wears, it creates inflammation. So what you're actually doing is you're not changing anything as far as to that knee. You're just helping your body not to feel that inflammation. So the only downside to that, or that some people run into, and first again, if that's my job and I'm a family doctor, or I'm a nurse practitioner, or I'm a PA, or I'm an orthopedic, there's certain steps you have to follow. And hey, if you come to me for help, that's what I'm going to do. I'm going to try to help you. what
Right.
more people are learning though, and they're trying. I have people that go say, I've been hearing more about the cortisone shots and how they actually destroy the cartilage in between your knee, and that is true. So the doctor's not doing anything to try to harm you. So please don't think that that's the case. They're just giving you the tool they have, the tool they have, or the whether it's a tool or whether it's a gun or whatever they've got. That's the option they've got. So they're just trying to help you. So they're giving you the best option they have. You come in, you say, hurt. I said, I've got a shot. Stick a shot in it. It feels better. Yeah, it felt better for a couple of weeks, but it's right back again. We got to wait a little while, but we'll stick another one there. The curveball that we run into, steroids will actually break down the cartilage in between your knee, which will lead to that actually breaking down further and actually becoming more bone on bone. So downside is it causes it to wear out. Good upside is it gives you some temporary relief. And what most people find is that the more they get, the less effective they are, especially like with cortisone or epidurals in the back. When they go in the epidural space and actually do injections in the back, they'll usually, like, I have some patients will say, yeah, I got 2 or 3 weeks out of that first one, or I got a month out of the first one. I had some people that's had them longer, but most people, the first one will last about a month, second will last about 2 or 3 weeks, and then the third one either lasts a day or two or doesn't work at all. And there's there's exceptions to every rule, so I'm not saying that you don't get more relief. The downside of that is that a lot of them say, hey, I don't want to chew my disc up what I've got because that's going to lead to a major surgery. In the knee, we're talking about a replacement. In the back, we're talking about a fusion, which is a big deal. It's a real big deal. So, so when we're talking about that, when we're talking about the injections, probably the next step is to actually do what they call rooster comb or Synvisc. You ever heard of that before?
I have heard of rooster comb,
okay.
yes.
So
don't know much about it, but I've heard of it.
So basically, it's like a thick gel. So what they're doing is they're actually putting some like a jelly kind of thing between the knee to give it some cushion. So so when you push off of it, it gives it some cushion. So great. I have no problem with hyaluronic acid. So we'll say hyaluronic acid. We'll say Synvisc. We'll say rooster comb. They're all, to my knowledge, are all exactly the same thing, just different labels. Kind of like you'd say, grab me a pop, grab me a Coke, grab me a soda. We're all talking about the same thing, just a different term for the same thing. So when they do that, there's nothing wrong with it. Some people get relief from it. Some people, they'll usually start off with cortisone. And you got to think a lot of times, unfortunately, insurance dictates a lot in healthcare. Back years ago, you could do what you felt was the right thing, especially in medical. In mine, I'm a little more enchained in our practice than, say, your typical orthopedic or family practitioner. They have to follow a protocol. The insurance dictates that we got to do this, then we got to do that, then we got to do this. And I've had patients say, I think they're just trying to drag you along so that way that you'll just quit doing it. I'm not going to disagree with that. I'm not going to say that's what's going on, but like they start off with cortisone, then they do the hyaluronic acid, then they want to do a replacement. So with the hyaluronic acid, I have no problem with it. In fact, with some of the technology we use, it actually only helps add to it, actually only benefits it. Whereas when we're doing some technologies, if you've had a cortisone shot, we have to wait a month because it actually will not allow tissue to grow back in between your knee. So with the hyaluronic acid, you have no problem with it, or that we call it rooster comb, Synvisc, not an issue. The third thing is, surgically wise, is typically the knee, obviously if you tear like a ACL or a medial collateral, that stuff's going to have to be repaired. And I have a lot of patients that don't do it, and it'll actually grow back, and they'll be okay. But I'm not going to promise that that's the case. If you have a pretty bad tear, sometimes you have to go there and just have to replace it. I mean, or have to replace it, you have to fix it. Sometimes you use a cadaver, or sometimes we use other things to do that. Nothing wrong with that. That we're having more and more people that they used to do. You remember like a meniscus surgery where they like trim the meniscus? You ever heard of that, Cousin Andy?
I have heard.
So years ago, that was a go-to. If you had a tore your meniscus on the inside, they would trim it, which means they take part of that cartilage out. You'd go, oh, that took the pressure off. The downside is that it takes more of that shock absorber out. So when you take that shock absorber out, it wears down even faster. So if you trim it, it tends to make it wear out faster. So, and what they're finding in some studies is if you just give it a little more time, a lot of times it'll eliminate itself. And I'm not saying that's for every case, but a lot of studies are coming back and saying we really don't need to do it. So you're seeing the meniscus surgery less often, and insurances aren't paying for it as quickly as they did before. So they're not whipping that out quite as much. Plus the studies are saying, hey, it really don't change a lot. For some people, it really can make a huge difference. But then, like, a few years down the road, they're replacing their knee. So there's a pro and con to everything. Just like with anything in life, there's a pro and con, right? If I come home every night at 1 o'clock, I may not have a wife, but I might can stay out later, right? Or I might come home, and my wife would not do this, and there might be somebody else there. So you get what I'm saying? So my wife wouldn't do that, but I'm just using it as an analogy. If I'm not home, sometimes somebody else, I guess it could leave room for somebody else. Not that my wife would do that first and foremost, but you get the point I'm trying to make. So there's always exceptions to rule. So the last but not least is where they do a replacement, and they actually saw off the femur. They saw off the tibia, and then they actually and they actually take and they drill up the bone, and they drill down the bone, and they tap in this like rod, and they tap down to the rod, and they put like a new piece of metal that's kind of in between. So nothing wrong with placements. Sometimes they are absolutely needed, and I refer out to them I used to refer out to them all the time. I'm finding that we rarely have to refer out for a knee replacement anymore because there's some newer options out there for people. With the knee replacement, the curveballs we run into this, and I'm sure you've heard the same things. Have you heard of people that say, man, I really thought the knee replacement would do well? About half of what we're seeing, half the people that get them are like love them. I actually had a lady that came in today, and she said, hey, my knee did great. It's awesome. I just don't want to have to go through that all over again. So I said, no problem.
A lot of the recovery's rough on that.
Recovery. Yeah. And her recovery was actually probably one of the best that I'd heard. She said she actually felt better within a few months. Most of my patients, it's usually 6 months to a year. So a long time recovery, which is probably what you've heard. And most people just don't have it. And they're having to go to a therapist constantly, if you have a knee replacement, you need to go to physical therapy. You really need to, do that. But they're spending, 3 times a week for months in a physical therapist's office to get that strength built back where they've replaced it. So there's a time and place for everything. Just like with back surgery, there's a time and place for back surgery. However, with knees, a lot of people are looking for other options. So we're going to talk about some more of that stuff in a moment. So with a knee replacement, there's a time and place. Like I said, recovery can be long, and results. My mom's had her, and I'm trying to remember, her right one she's had done twice already. Her left one I think she's just done her left one once. That's before I started doing all this stuff. So she's probably mad at me right now, saying I wish you'd have gotten on the board and doing some of this newer stuff, but that was, sorry, Mom, I failed you. I apologize, but I'm trying to do better. All I can do is move forward, right? So at any rate, so nowadays there's some different things. So let's talk about some different options you got. So number one is there's a new technology called orthogen. And with orthogen, what it does is it uses, what depends on the type of situation. If there's a biomechanical problem, you can actually go in and you can actually change the biomechanics of the knee so that way we say it articulates or it moves properly or as close to properly as possible, which doesn't allow it to chew down that cartilage anymore. So that's one aspect. Some people don't need that. We test for that when we come in, and a good doctor should always test and not just automatically assume that's what you need. But that's to the biomechanics we check. Another thing is there's new technology out there with orthogen that actually forces stem cells in between the knee. And what it does, it actually shoots a frequency in the cell wall. The cell wall will respond by accumulating the stem cells in your body. And as you get older, you don't have as many of them as you did when you were younger, obviously. So it localizes it in there. It actually helps to regrow that tissue back. And we have people that'll actually, you'll start to see on x-ray that they'll start to widen that area back up after it's been treated. We also, in some cases, we use robotic lasers, which will actually help to speed up the healing process and help to give pain relief as well. So there's a lot of different options out there for somebody who had as a knee problem that really don't have an option. In fact, I want to say yesterday I had like 2 people, no, that was maybe it's Monday, had like 2 people from Greensboro, have had people, they're coming from all over because they're looking for other alternatives. So my goal today was just to really break down what options there are, how how the knee works, different things that you can do. And don't get me wrong, there's a time and place for surgery. So if you have to have surgery, we do the best. Find a good orthopedic, find a good physical therapist, and follow through. There are a lot of good orthopedics out there. They're just like carpenters, like there are mechanics, like there are chiropractors, like there are dentists. And you, Dr. Cousin Andy, you're an excellent radio show host, but you probably know some that you wish that they would find another career, right? Obviously, they're not at
No
WBRF,
comment.
different radio station, but you get the point I'm trying to make. So there are good and bad. In fact, in the medical community, they call it having good hands. In other words, you're a good surgeon. You can be a brilliant person, but not be a good surgeon. It takes a it's a feel type of thing. Also, just like with chiropractors, same thing. Just like with any doctor, like family doctors, there's not as much hand involved, but you have the caring aspect, and if you have to care, right? So, there are options. Sometimes the only options you have is surgery, but the good thing is there's options now with OrthoGen. We're having, I bet, roughly 92% of our patients are doing phenomenal with that. And most will get at least 80% results, 80% recovery, so they'll get a lot of their pain back. And there's more and more people there's more places. I think we're the only one in North Carolina doing that, but there are some up the North Carolina and Virginia. But hopefully in the future there'll be more that's starting to pop up that are doing that new technology. But as time goes on, more and more physicians will learn about it. It's just pretty new out there. And we have seen some of the people that's getting the stem cell injections where they actually inject stem cells in there. In fact, that's how I came upon this. The problem was the FDA had a lot of problems with the regulations of them, and they pretty much shut down a lot of the stuff that was actually more beneficial. We're hoping that they're going to change that in the next few years and allow us, because we actually was actually going to start doing them in our office, bringing in different providers to start providing that assistance. But the success of it was so low, and I think it was like, I've had patients tell me that they were paying from places like $10,000 a knee and with 30% success rate. So wasn't something I felt confident with doing in my office with that low of success. Hopefully in the future it'll improve, and if it gets to the point where we're seeing high success, I may even add that into what we're doing. But right now we're having such good odds, we don't have to do that, and the cost of doing OrthoGen is a whole lot less than that is. So it gives a patient opportunity to get better without spending a ton of money out of their pocket. But other than that, any questions you can think of, Cousin Andy, for me?
You got a lot of things there, Dr. Delp, that people need to look into before actually having surgery. It sounds like you can maybe help out some of the people.
Yeah, absolutely. And the orthopedic said, and he was, he's kidding with me, but he says the only downside of it is when I replace it, I can't go back you can't go back. They don't store their knee in the back. And I say, that didn't work out good. Let's just put your other one back in there. Once that's done, that's done. He said, it's always good to exhaust all your options before you have, whether it's back surgery, whether it's hip surgery, whether it's shoulder surgery. There's a time and place, but once that's done, you can't go back up. That missile's launched. It's already gone. So try to find options no matter what they are, no matter who they are. Try to find all the options you can before you go do a surgery. And any good surgeon's going to tell you that. Any good, honest surgeon's going to tell you that. So try to find your options, because once you pull that trigger, you can't really back up. So there are options, thank God, now that have really, really good outcomes. But like you said, we're here. The big thing is you focus on the patient, then everything works out, right?
That's right. You got to find out what's wrong with the knee first of all, right?
Well, and you'd be surprised how many patients we have come in. Then we're examining them. They have a back component or a nerve component coming from their back that causes some of their pain in their knee, and they'll have weakness in their. And so instead of doing, we think we're going and doing one thing, but we end up having to do 2 or 3 different things in order to get the maximum success for that patient. Where if you'd only treated just the knee and didn't do the back, if a person has the nerve issue out of the back, their success is, they might get 40 or 50% results. Where you start adding that in, they bump on up to 80, or even, I have some people that claim they're 100% better. I will never promise that with a 75 or 80-year-old person. But I use this statement a lot. It's like, I'm not going to turn you into a 16-year-old. And the reason why I say that is because I want to give good, a likely objective. 80% better, yeah, we can do that. Or, we can get you 70% better. Or, hey, you're probably going to get 90% better. You're young. We got a lot of you can do that. But you want to make sure you give good measurable results there, so that way somebody knows, hey, I'm not going to be running a marathon when this thing's done. But man, I can go shopping. I can go play with my grandkids. I can. I don't throb and I can sleep at night. Those things, a lot of people, that's what they're really going after. They can't play golf. They can't do the things they like to do. They can't go hunting because it kills them afterwards. It swells up. So being able to provide options for people, that really makes me smile.
Absolutely. Thank you, Dr. Delp. Good information this morning for everybody.
Thank you very much. And Tom, are we going to going to stay on after this, or we're going to be taking some questions afterwards? And we got a few, and you can do so. Cousin Andy, first of all, I'll tell you goodbye because I know you've got other things to do. But you have a good one, and we're going to be taking some questions live on TikTok, and that is at Dr. Delp Cairo. So if you pull that up, we can take some questions from there. Okay.
Thank you, Dr. Dale. Appreciate it. Have a great day now.
Oh, thank you, Cousin Andy, and you have a good one. And enjoy this weather, and Happy Easter, a.k.a. Happy Resurrection
Easter.
Day, right?
Thank you. That's exactly right. Happy Easter, Dr. Dale. Thank you again.
Thank you. All right, so there's stuff coming on. Now, y'all have to excuse me out there because I'm technically not savvy, so I've got Tom is much more technically savvy than I am. So we're going to hold on, he's fixing this up. We're going to take some questions. Let's see. I saw some stuff come on the screen. We got any questions? Anybody from the chat? We got 0 people in here. Okay. Well, that's better. Okay. All right. Well, so we're gonna at this point in time, the questions haven't came in yet. We're gonna go and cut it off. But in the future, if you have any questions, please get ready, write them down, and let us know. We'd love to help you out. Thank you very much, and you have a great day.